Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. You can join our Telegram group to get all lecture related information. We also have a Google Drive where you can get access to all the PDF of lectures, and there's a master integration key by MIKEY by which you can navigate between the PDFs and the YouTube. These are the disclaimers. And we are in phase 3, which is the recorded pathology lectures. And today it is something special. This is the Eid Day special, which is Pursue 1P Uropathology. And we have kidney, embryology, gross anatomy, and histology. And to talk on that, we have Dr. Mitadru De Sarkar, who is an MBBS from JIPMER, MD from JIPMER. He's a consultant histo and cytopathologist and laboratory head and overall quality in charge of the famous Calcutta Heart Clinic and Hospital, Kolkata. He's also the consultant histopathologist at Wizderm Pathlabs, a specialty dermatopathology laboratory. He has been an ex-assistant professor in the Department of Pathology at SMV Medical College and Hospital, and also an ex-consultant pathologist at the SRL Diagnostics, Fortis Hospital, Anandapur, Kolkata. Dr. Mitadru De Sarkar has authored a book which is titled Brain Tumor Pathology for Postgraduates, which is an NVS publication, and that is available on Amazon. It is also available on Kindle, and you can also get hold of this book. This is the link. So without much ado, I would request Dr. Mitadru Sarkar to start his lecture on the basic aspect of uropathology, which is the kidney, gross anatomy, embryology, and histology. Over to you, Dr. De Sarkar. Thank you so much.
Hello. At the onset, I would like to thank Dr. Nadeem sir for having given me a chance to present this series of presentations on the genitourinary tract in his online lecture series. In this particular discussion, we shall be talking about the embryology of the kidney, its relevant gross anatomy, and the corresponding histology. We'll start off with a brief discussion of the renal embryology and its corresponding gross anatomy. Now, as we already know, the kidney development goes on through 3 important successive stages. These are the pronephros, mesonephros, and the metanephros. All of these 3 structures are formed from the intermediate mesoderm. So the pronephros is a very, very transient structure, and its only job is to give rise to the mesonephric duct, which actually gets incorporated into the next renal system that ultimately develops, that is the mesonephros. The mesonephros, the only contribution of the mesonephros to the formation of the renal system is that it forms the initial series of glomeruli, which are again transient. 7 to 15 glomeruli are actually formed by these mesonephros. The main job that the mesonephros performs is the formation of the mesonephric duct, which gives rise to the efferent ducts of the epididymis, the vas deferens, and the seminal vesicle. And in the females, it actually persists as the remnants of the epiphoron and the paraphoron and the Gardner duct. It also forms the Mullerian duct, which will give rise to the female genital tract organs. It remains functional until the end of the 4th month of gestation, when it is replaced by the final renal system, that is the metanephros. The metanephros actually is a mass of condensed primitive mesenchymal tissue, also known as blastema. Under the induction effect of the mesonephric duct, the metanephros develops into a hollow structure known as the ureteric bud, which ultimately gives rise to the renal pelvises, the calyces, and the collecting ducts. At the same time, the ureteric bud also causes induction of the metanephric mesenchyme and its subsequent differentiation into the structures of the permanent nephron, comprising of the glomeruli, the proximal and the distal tubules, and the Henel's loops. So in this illustration, in this picture on the left that we see, we have got towards the left the metanephros, consisting of the rudimentary primitive tubular structures as well as the glomeruli, and towards the right we have the inducing mesonephros, which will ultimately give rise to the Wolffian duct and the Mullerian duct. So if you see this particular illustration, this is the intermediate mesoderm, which is composed of 3 important parts. That is the segmented intermediate mesoderm, or the pronephros, the earliest, which does not contribute to the kidney in any way. The unsegmented intermediate mesoderm, that is the mesonephric system, which will give rise to the mesonephric duct. This mesonephric duct will interact with the unsegmented mesoderm of the metanephric system, As a result, this metanephric system will ultimately differentiate into the ureteric bud, which will give rise to the renal pelvic LICL system, and it will also induce the metanephric blastema to give rise to the glomeruli and the tubules. So this small illustration shows all there is to know. So at the end of the day, all we have to remember is that the formation of the kidney is mostly dependent upon the mesonephric duct, which causes the induction of the metanephros into the ureteric bud, which in turn gives rise to the renal pelvic LICL system. And at the same time, the metanephric mesoderm gives rise to the structures of the permanent nephron. So in this picture, as you can see towards the left, we have a portion of the mesonephric kidney, which consists of these primitive immature glomeruli that are formed from the mesonephros. And towards the right, we again have the condensations of this metanephric blastemal tissue giving rise to the structures of the primitive renal tubules and the primitive glomeruli. Now, coming to the localization of the kidney, we already know that the kidneys are paired and they're retroperitoneally in location. The superior poles are situated at the level of the T12 and L1, while the lower pole is at the level of the L3. When it comes to the orientation of the kidney towards the posterior superior aspect, we have got the diaphragm. Posteriorly, we have got the psoas major muscle and also the quadratus lumborum and the aponeurosis of the transversus abdominis, which joins it laterally. Anteriorly, depending upon whether it's the right or the left, you have relation to the liver, right colonic flexure, the descending part of the duodenum, and towards the left, you have the relation to the stomach, spleen, pancreas, left colonic flexure, etc. If we look at the outer aspect of the kidney, we find that there is a condensation of this fascia, that is a fibromembranous structure, which in turn joins to the transversalis fascia. So this is in brief, an idea about the localization of the kidney in the body. Now, if we were to strip off the renal capsule from the outside surface of the kidney, we would see, especially in the case of the fetal kidneys and in the very, very young child, we would see this kind of distinct lobulations which are present on the surface. With the passage of time, as the kidneys become adult, these become inconspicuous. However, that having been said, some adult kidneys do have these persisting fetal lobulations. So that's something that is to be kept in mind. These fetal lobulations kind of correspond to the renal lobes, but not exactly. So if you see this, there are two adult kidneys which have had their capsule removed. So towards the left is how the adult kidney usually looks. That is, you don't have these fetal lobulations persisting. On the other hand, towards the right, you have this adult kidney where you have these distinct fetal lobulations. This would be seen in the newborn, but in the adult, it will be unusual, but still it may be seen in a few of these adult kidneys. Now, coming to the brief discussion of the renal anatomy. From the outside in, you have got the renal capsule, which is again surrounded by the perinephric fat, which is covered by the gyrotous fascia. And going inside towards the substance of the kidney, we find the outer layer, which is the cortex, and the inner portion, which is the medulla. Now, if you look at the medulla, it's actually composed of these pyramidal structures known as the medullary pyramids, which have got a broad base, which faces the cortex, and a narrow apex, also known as the papilla, which joins into the minor calyces. So, as you can see, the cortex is kind of condensed around the medulla, and it seems to encompass the entire renal medullary pyramid. So the condensation of the cortex are known as the columns of Bertin. So these columns of Bertin are actually the condensation of the renal cortex which surround the renal medullary pyramids on both sides. These are also known as the septum of Bertin. So going from the outside in, we have the renal cortex, the outer aspect of the renal cortex, and the columns of Bertin, which surround the renal medulla. And these renal medullary pyramids ultimately drain into the minor calyces, which again drain into the major calyces and ultimately joining into the renal pelvic LICL system. This entire structure, which is composed of the renal pyramid with the surrounding renal columns of Bertin, is known as the renal lobe. This is not really a functional unit, rather it can be viewed as an anatomic organizational unit of the kidney. Now, the cross-section of this kidney seems to illustrate this particular facts well. So going from the outside in, you have got the renal cortex towards the outer aspect. You have got these medullary pyramids, which are again surrounded by the columns of Bertin. And these medullary pyramids are again opening at the papilla into the minor calyces, and these minor calyces join into the major calyces, ultimately draining into the renal pelvic-ureteric junction. So as you can see, you have got the cortex towards the outer aspect, you have got these medullary pyramids, and if you see from the base of the medullary pyramid going towards the outer aspect, you have got the fine condensations which will be seen histologically in the form of medullary rays which ascend into the overlying cortex. So this is the renal medullary pyramid with a broad base surrounded by the column of Bertin, and it has got the draining papillary tip which drains into the minor calyces. Again, this particular illustration is very important because when you do a grossing of the kidney, this is how it will look, and you need to be able to identify the individual components of the cut section of the kidney. So as you already know, you have got the renal cortex towards the outer aspect, you have got the medullary pyramids, you have got the renal papilla which drains into the minor calyces, you have got the broad base of the renal medullary pyramids, and this entire fatty structure which is seen in contiguity with the renal papilla is the renal sinus fat, and this is a very important landmark. You will need, while grossing, you will need to take intense precaution as to see that you have sampled this particular area. As you see, there's a small tumor which is seen towards one of the poles, and in this particular discussion, this is very pertinent to note that this capsule which is present on the outer surface of the kidney is actually missing when you see the inner aspect of the kidney which faces the renal sinus. That means that any tumor which is present in this particular location close to the renal sinus has got a direct access to the sinus fat, and we already know that this renal sinus is rich in the renal vessels as well as the lymphatics, so there's a very high chance of invasion through this renal sinus fat into the corresponding vessels and a hematogenous dissemination. So this particular landmark needs intense scrutiny for invasion of a renal tumor. The same fact what I've already said, as you can see, this thick dark blackish condensation of the renal capsule is missing in the region of the renal sinus, and you have got direct access of the renal medullary pyramids at the papilla into the renal sinus, and the pelvic calyceal system is also situated within the renal sinus. The same illustration which shows the histological correlation, the lower picture towards the left, you see the renal medullary parenchyma which is in close proximity to the renal sinus fat along with this vasculature. Towards the right, you see the effect that a renal tumor might have. You have this tumor which is situated very close to the renal sinus fat, going and directly invading the fat of the renal sinus. And any invasion of this renal sinus fat would automatically make it a PT3A stage. So this particular illustration shows you the various relations that a renal tumor may have in relation to the kidney and the corresponding effect on the stages. So if you see the image towards the right, you can see various scenarios. So you can have a tumor which invades through the capsule into the perinephric fat, or the same tumor might invade the renal sinus. It might even involve the renal vessels which are situated at the level of the sinus. All of this would actually be PT3A stage. On the other hand, a tumor which is located towards the upper pole might go and directly invade into the adrenal, in which case it would be T4. However, if you were to see a tumor nodule sitting in the adrenal, but which is separate from the main tumor mass, even after giving serial sections, that would count as a discontinuous adrenal invasion, and that would be of stage M1. Since we have already talked a little bit about the effects of the invasion of the renal tumor on the various structural compartments of the kidney and its adjacent tissues, we'll talk a little bit about the rudiments of grossing, which are pertinent as far as this particular discussion is concerned. So if you were to get a radical nephrectomy specimen and if you were to lay it on the side, this is how it would look. So you have the entire mass which is surrounded by the perinephric fat with the overlying gyrus fascia. You have the ureter, which has been drawn out with a clamp, and you have these various staples which are present at the renal hilar vascular margins. The first job is to obviously take out these staples and to snip off the vascular margins that you are getting at the hilum, along with the section, along with the snipped off distal end of the ureter. You then will try to dissect through the ureter and approach the renal pelvic ileal system and then bivalve the kidney. Once you have bivalved the kidney, and if you have a tumor, these particular relations of the kidney become very important. Especially, as I said, sampling the renal sinus fat becomes very important. In this case, you have got a renal cortical based tumor, which is encroaching into the region of the medulla and bulging into the renal sinus fat. So these are areas which you would need to sample really well in order to check for renal sinus fat or vascular invasion. So these are the important sections that you need to take in a radical nephrectomy specimen. These are the bare minimum sections that you should be taking actually, because you will have to stage this particular tumor and the various orientational landmarks become important. So for example, this particular area towards the inner aspect is what shows the relation between the renal tumor and the renal sinus fat. So sections from these are important. You have this renal cortical tumor which is bulging out towards the region of the cortex and pushing into the capsule. So a perpendicular section of the tumor with the overlying perinephric fat margin becomes important. Just not one, multiple sections where you feel that the tumor is going and bulging into the perinephric fat and probably invading it. You will also need to give sections which show the orientation of the renal capsule and the adjacent kidney. Normal kidney bits also have to be given, and of course sections from the adrenal. If your tumor is located somewhere close to the upper pole, then you need to give multiple sections to show the relation between the renal tumor and the adrenal gland. Now coming to a brief discussion of the renal histology. The first thing that we will have to discuss when we talk about renal histology is the relation of the structures that you see under H&E to those of the individual components of the nephron. So if we go back to the basic description of the nephron, we already know this structure. So it's basically composed of the renal corpuscle, also known as the Malpighian corpuscle, which comprises of the glomerulus, the twisted mass of the glomerular capillaries, which is surrounded by the Bowman's capsule. This will ultimately drain into the proximal tubules, which again has got a twisted part and a relatively straight part. The relatively straight part opens into the descending the thick loop of Henle, which in turn becomes the thin descending limb of Henle, goes up, becomes the ascending thin loop of Henle, going on to the ascending thick loop, which ultimately joins by the connecting tubule into the collecting duct that will ultimately drain into the renal pelvis. Now there are actually two types of nephrons, and the majority of the nephrons are those nephrons which are located at the level of the cortex. The main difference that we see between the juxtamedullary nephrons and the cortical nephrons is that the cortical nephrons have got very short loops of Henle, while the juxtamedullary nephron have got pretty long Henle's loops which dip quite a bit distant into the medulla. So now coming to the discussion of the various layers of the kidney under the microscope. So you have got an outer renal cortex, which forms a 1 centimeter thick layer, which extends from beneath the renal capsule and in between the renal pyramids, pyramids forming the columns of Bertin, like we've already discussed. And it is actually composed of two important architecture regions. One is the cortical labyrinth, the other is medullary rays. Medullary rays can be actually thought about as rigid extrapolations of the medulla into the cortical parenchyma. The bulk of the renal cortex will be composed of the cortical labyrinth, which again is composed of glomeruli, especially the proximal convoluted tubules, but also a part of the distal convoluted tubules, the connecting tubules, and the very initial portions of the collecting ducts. Along with them, you also have all the other arteries, veins, arterioles, the entire vascular system, along with the lymphatics, which are situated in close proximity to the tubular elements. And of course, the glomeruli are one important component of the renal cortex, which helps to separate them from the medulla, because the medulla will not have these glomeruli. And the base of the renal pyramid is what we have already said, has these perpendicular extensions going into the cortex, which are known as the medullary rays. These medullary rays, although they have the name of medullary rays, they are actually part of the cortex and contain the straight segments of the proximal tubule, and most importantly, the thick ascending limbs of the loop of Henle, as well as the collecting ducts. So if you see this particular illustration, you can see that towards the top, you have got the renal capsule. Then going down, you have got the glomeruli, which this is actually a kidney at 2 months of age. So you still have the glomeruli, which are in a very compact, organized fashion. As the age advances, this expanding mass of renal tubules will push this glomeruli apart. However, you see the various tubular elements of the PCT as well as the DCT, which are present in the cortex. Along with that, you have these linear, almost perpendicular extensions of tubular elements, which are actually called the medullary rays. In this particular illustration, this thing is illustrated very well. You can see these glomerular elements, which are shown in the large blue with the large blue arrows. You also have got the renal tubular elements. And most importantly, you have got these linear extensions, which are marked out with black, which extend all the way from the medulla into the cortex, that is the medullary rays. So in one of the sections, this medullary ray might come across as this perpendicular, almost 90-degree penetrating tubular elements, which kind of appear to dissect through the renal cortex and separate the tubular elements and the glomeruli. However, if you were to see the same elements in the cross section, you would see them out as that, as if you are just looking down from the top of this tubal group. So you would see just the outer aspect of these tubes in a form of a conglomerate. So that is how the medullary rays will look in the longitudinal section and in the transverse section within the renal cortical parenchyma. So in this particular illustration towards the right, you see the important structures which are present in the renal cortical parenchyma. You have got the glomeruli, which are present within the Bowman space. You have got the renal tubules, mostly the proximal convoluted tubules, but also to certain extent the distal convoluted tubules as well. And you have got these clumps, or rather these congeries of tubular elements, which are actually the medullary rays, which are seen in the transverse section. In this particular virtual slide, this fact is illustrated very well. So you have got the glomeruli surrounded by the Bowman's capsule. You have got the various tubular elements of the PCT and also the DCT. And these linear extensions that you see over here, almost transgressing across the thickness of the renal cortex or the medullary rays, which again are composed of mostly the collecting ducts, but also the ascending limb of the loop of Henle, and also the distal portions of the distal convoluted tubules. At a higher power, you can actually separate the limb of Henle. So you have got the loop of Henle's can be distinguished from those of the collecting ducts by these hobnailed structures which are protruding into the lumen. So these hobnailed epithelium-lined tubular elements are the Henle's loops, while these elongated elements which are composed of cells having much more abundant cytoplasm, they are the collecting ducts. And these are dissecting through the renal cortical parenchyma, separating the glomeruli out. On a PAS stain, that is a periodic acid shift stain, this can be illustrated even better because they tend to highlight the basement membrane element of the tubules. So towards the left, you have got the medullary rays, which are dissecting through the renal cortical parenchyma, and towards the right, you have got the proximal and the distal convoluted tubules of the renal cortex, which are surrounding the glomeruli, which are again enclosed within the Bowman space. Now you have got the cortical labyrinth again, and this is a dual stain IHC, which in which the counter stain, that has been used is both DAB as well as fast red. So the two IHC markers that have been utilized in this particular section are CD31 in order to point out the vascular elements, and smooth muscle actin in order to point out the muscle wall absence or presence within these vascular elements. So you see that the glomerular capillaries as well as the vascular lining of the arteries, arterioles, venules, as well as the capillaries have all been stained brown, meaning that they are CD31 positive structures. At the same time, the thick-walled arteries, that is the interlobular arteries, and the arterioles have the reddish, fast red stained smooth muscle actin within their walls, while the venules and the capillaries do not have smooth muscle actin. So this is how the cortical labyrinth will look. Starting from the outer aspect, you have got the renal capsule, and as you go in, you have got these glomeruli which are surrounded by the Bowman's capsule, and again which are surrounded by the proximal and the distal convoluted tubules. So these are the three most important structures which are present in the cortical labyrinth. The Malpighian corpuscle, which is actually the mass of glomeruli which is enclosed by the Bowman space, the proximal tubular elements which are situated in close proximity to the Malpighian corpuscle, and the distal tubular elements. From this particular illustration itself, one thing is pretty clear, that morphologically itself, we can actually segregate the proximal tubular elements from the distal tubular elements. The proximal tubular elements have got larger cells with much more abundant eosinophilic, dense eosinophilic cytoplasm, while the distal tubules have cells which are much smaller and with much scanty amount of cytoplasm, and they are also smaller in size compared to the proximal convoluted tubules. Now coming to the glomerulus, which is one of the most important structures present within the cortical labyrinth. As we have said, glomerulus is basically nothing but a mass of capillaries. But when we talk about the glomerulus, we also talk about the investing structure which surrounds this glomerular capillary mass. So this entire structure which surrounds the glomerular capillaries, along with the capillaries, is what is known as the Malpighian corpuscle. So we can say that a Malpighian corpuscle is actually the sum total of the glomerulus, which is surrounded by the capsule of Bowman. And this capsule of Bowman has again got two layers. Starting from the inside and going towards the outer aspect, you have got the visceral layer, which is sitting atop of the glomerular capillary loops, and which have cells which are known as the podocytes. And then you have got the separation by a clear space, that is the urinary space, that is the Bowman space. And this again is surrounded by an outer parietal layer, which comprises of simple squamous epithelium. And this simple squamous epithelial lining continues downward into the tubular elements as the simple cuboidal epithelium of the proximal tubule. Now this aspect where the Bowman space opens out into the proximal convoluted tubule, which is present in its vicinity, is known as the urinary pole. So every glomerulus has got a urinary pole which opens into the PCT, that is the proximal convoluted tubule, and facing that pole towards the opposite aspect is the vascular pole, which actually receives the afferent arteriole, which springs out from the interlobular arteries and makes way for the efferent arteriole, which basically collects the blood out from the glomerulus and takes it out. And in very close proximity to these arteriolar structures is what we know as the juxtaglomerular cell, and this harbors the important structure known as the macula densa. So basically, if we narrow down the structure of the glomerulus, we can say that it is composed of three important subunits. You have got the endothelial cells which line the glomerular capillaries. You have got the podocytes, basically, which sit atop the glomerular capillaries, and these podocytes are basically the integral component of the visceral layer of the capsule of Bowman. And you have got the mesangial cells which are sprinkled in between the glomerular capillary loops and situated within a matrix known as the mesangial matrix. This past stain shows the important structures which are present in the Malpighian corpuscle along with its important relations. So you have got this mass of glomerular capillary loops with the blood elements inside them, and you have got the podocytes which are sitting atop of these capillary loops, and going towards the inner aspect you have this pus stained magenta colored mesangial matrix in which you get these mesangial cells which are interposed within the matrix. And you also have the vascular pole. You have got the elements which are present at the vascular pole in the form of the efferent and the efferent arterioles. And this whitish, this clear space, this empty space which is surrounding the glomerular capillary loops is the Bowman space, and this is again invested by the outer layer, that is the parietal layer of Bowman, which is basically lined by simple squamous epithelium. This is the schematic of the normal glomerulus, which shows the relation between the glomerular capillary loops and its vascular pole. And exactly opposite to the vascular pole, you have got the renal tubular pole, which opens into the proximal convoluted tubule. Towards the right, we have the illustration of pediatric glomerulus. As you see, there is a bit of a difference from the adult glomerulus. The Bowman space is not that well developed. Rather, you have a very prominent layer of podocytes, this bluish colored large nuclei which are sitting atop the glomerular capillary loops. So you have got very prominent podocytes, and with passage of time, this representation of the podocytes will actually come down and they will become relatively inconspicuous. And these magenta colored structures, which are basically permeating the entire glomerular capillary loop network, is the basement membrane, which has been stained with PAS. In a case of a normal adult, this is how the glomerulus will look. So you have got the glomerular capillary loops with inconspicuous lining. However, you have got this matrix-like material between the glomerular capillary loops, that is the mesengium, and you have got the mesangial cells which are interposed within the mesangial matrix. Normally, the number of mesangial cells in one unit area should not be more than 3. If you have more than 3 nuclei sitting in a unit area of the mesangium, that would mean mesangial hypercellularity. And the relevance of mesangial hypercellularity will be talked about in the discussions of glomerulonephritis. This particular discussion is mostly about the normal histological landmarks, so I shall not be delving too much into the concept of mesangial hypercellularity. And if you were to stain this glomeruli with PAS, you would see that the basement membrane is nicely picked out in the form of the magenta red colored structures which are seen at the base of the glomerular capillary loops. This outer layer of Bowman is also nicely picked up on a PAS stain. However, the most important stain that is utilized to pick out the glomerular basement membrane is not the PAS stain, rather it's the Jones methenamine silver stain, which is a mandatory stain that needs to be performed if you are to assess the structure of the glomerulus. So you have these glomerular capillary loops, which are the open rounded tubular elements, tube-like structures which are present inside, and at the base you have got this black stained glomerular basement membrane, that is the capillary basement membrane, which is picked up with Jones methenamine silver. And Mason trichrome also highlights the important relations because it tends to pick out the Bowman's capsule as a bluish stained structure which is present around the glomerular capillary loops. You could use ISC in order to visualize the various structures of the glomeruli and its surrounding neighbors, but it's not utilized for this purpose. But in this case, I'm just showing these two images to highlight the fact that you can use CD31 to pick out the glomeruli and also the blood vessels which are situated in proximity to the glomeruli, and the podocytes which may be otherwise inconspicuous on a H&E stain can be picked up with CD10. So as you can see, this CD10 image towards the right shows the podocytes which are sitting on top of the glomerular capillary loops. Do you have an internal control built into this particular slide? Yes. Sorry, you have got this renal proximal convoluted tubular elements, and the brush border is nicely stained with CD10, showing that the stain is working. Now coming to the vascular elements of the renal cortex, we know that the interlobular artery is the major arterial unit which is present within the lobes, and this renal artery, interlobular artery, will ultimately differentiate into the afferent arteriole, which will drain into the glomerulus. So under the slide, the interlobular artery would look something like this. You would have a nice internal elastic lamina which can be picked up even with an H&E stain, and by the presence of that internal elastic lamina, you can say that you have got a large artery in the form of the interlobular artery. And here you can see the interlobular artery dissecting through the renal cortical parenchyma, which is surrounded by these rounded conglomerates of the glomeruli with the PCT and the DCT elements adjacent to it. And towards the center, you have this linear extension of the medullary rays which are penetrating into the renal cortex. This section has been stained with PAS. As you can see, you have got the interlobular artery which is marked with A, and which has again bifurcated into 2 renal afferent arterioles which feed into the adjacent glomeruli. Again, you have got the interlobular artery which is differentiating into the renal afferent arterioles. So this The image in the left shows the interlobular artery, which is bifurcating into the arterioles. These renal efferent arterioles, if you look at the image on the right, these renal efferent arterioles will enter into the glomerulus at the arteriolar end, that is at the vascular pole, and after and at the point of exit, it will go out through the efferent arterioles. If you look at the size, the efferent arterioles are usually thicker in size compared to the efferent arterioles. However, in the case of the fetal kidney, the glomeruli will not look like you see in the case of the adults. They will rather look like a very primitive structure in which the vascular capillary loops are not that well developed and the lining cells are mostly elongated, columnar, and very hyperchromatic. So this is a fetal glomerulus. You will need to know how to identify a fetal glomerulus, because when we talk about the kidney tumors like say Weems tumor, you would have to identify the primitive fetal type glomerular elements as well as the primitive fetal type tubules. So knowledge of how they look is very important. So we have talked about the renal cortex. We have said that you have got the glomeruli and the tubules of the proximal nephron, which are present in contiguity with the glomerulus. And we have also said that the renal medulla sends out the medullary rays into the renal cortex. However, if you see the image on the right, that is the renal medulla, it does not quite look like the renal cortex. The tubular elements here seem to be pretty widely spread apart, and you have much more extensive interstitial element between the tubules compared to what you can appreciate in the renal cortex. Now, what are the important tubular elements present in the renal cortex? As I have said, the bulk of the tubules will be the proximal convoluted tubules, but you will also have a smaller representation of the distal convoluted tubules at the same time. So if you see the image on the left, you have got these proximal convoluted tubules, and how will you make them out? You can make them out by the abundant granular eosinophilic cytoplasm. They are very granular and eosinophilic because they're basically rich in mitochondria. And you also will be able to appreciate these brush border like structures which are present within the proximal convoluted tubules, but these are better highlighted with the special stains like say PAS. In the image towards the right, you have got the proximal convoluted tubular elements which have very well accentuated brush borders, as you can see. And towards the 6 o'clock position, you have got the glomerulus. Again, on the H&E section also towards the left, you see well-developed brush borders of the proximal convoluted tubular elements, and these brush borders are picked up in a better way by doing a PAS stain. As I have already said, the brush borders can also be picked up with immunohistochemical markers like CD10, and of course, you could also appreciate them on an electron microscopy. So this particular illustration that shows you both the types of tubular elements. So you've got the proximal convoluted tubular elements, which are marked out as PCT, and you've got the distal convoluted tubular elements marked out as DCT. So between the DCT and the PCT, the difference is obvious. PCT, the tubular cells are larger with much more abundant eosinophilic, dense eosinophilic cytoplasm and you can also appreciate the brush border like elements, while the DCT, the cells are smaller with much scanty cytoplasm and the brush borders will not be seen. So there are the various points of identification of the proximal convoluted tubules and the distal convoluted tubules. And in this image towards the left, you have got these nicely stained lysosomes at the same time. Now, what about immunohistochemistry when you want to separate the various tubular elements in the renal cortex? You really will not need IHC, but if we are to talk about IHC, there is a little bit of segregation as far as the expression of cytokeratins is concerned. If you were to utilize low molecular weight cytokeratins, like say cytokeratin 818, you would see that all the tubular elements get stained with CK18. However, if you do specific cytokeratins like cytokeratin 7, you would see that it is restricted only to the collecting tubular elements which are present within the medullary rays and the distal convoluted tubules, but the proximal convoluted tubules will not express cytokeratin 7. However, if you were to do the plasma cell associated marker, that is CD138, you would see that this element is present in the proximal convoluted tubules, but is not expressed in the distal convoluted tubules. Now coming to the renal medulla. The renal medulla can be actually divided into two important layers, that is the outer medulla and the inner medulla. The outer medulla, again, you can differentiate it into two layers, that is the outer stripe and the inner stripe. The outer stripe is comprised of the straight lower portion of the proximal tubules, the collecting ducts, and the distal portion of the straight tubules, which is also known as the thick ascending limb of the Henel's loop. The inner stripe, on the other hand, is composed of the thin descending limb of the Henel and the straight portion of the proximal convoluted tubule. The inner medulla, on the other hand, is mostly comprised of the collecting ducts, also known as the ducts of Bellini, but they also have portions of the thin descending and the thin ascending limbs of the loop of Henel. And as the renal medulla reaches the peep, reaches the papillary tip, which opens into the renal calyx, you will find that the epithelium of these collecting ducts will ultimately get transformed into the urothelium of the collecting ducts. So in this particular illustration, if you see, you have got this particular nephron, which is composed of the glomerular capillary loops, which undergoes transition into the tubular elements, which is again descending into the loop of Henel. As you go lower down, you see that the loop of Henel becomes thin. So bulk of the thin limb of the loop of Henel will lie towards the inner medulla, and also the collecting duct will be present mostly towards the inner medulla. So this is a slide which shows the composition of the renal medulla, and the elongated structures are mostly the collecting ducts as well as the thin limb of the loop of Henel. A portion of the distal convoluted tubules will also be present, but as you see, the image towards the left is that from the cortex. And how will you differentiate it? Because you have got the mass of the glomerular capillaries which are sitting over here. And the loop of Henel on the right hand side gives us an idea of how the cell of how these particular elements can be differentiated from the PCT and the DCT. As you can see, these cells seem to have a hobnail kind of appearance, which kind of go into the lumen. And at some places, this loop of Henel, the cross sections of these Henel's loops might be a bit difficult to differentiate from the capillaries, which are present in close proximity, because as you already know, the vasa recta are present in very close proximity to the loop of Henel, and you will identify the loop of Henel from the vasa recta capillaries by the presence of the RBCs in the latter. So if you see this medullary region of the kidney, you can see that the bulk of the component of the medullary region of the kidney will be the thin descending limb of the loop of Henel, the vasa rectae, and the collecting ducts. So if you look at the image on the right, you will see that the thick segments of the loop of Henel, the cells have more abundant cytoplasm and they're larger, while the thin segments of the Henel's loop have very, very thin wall with a very inconspicuous layer of epithelium which is sitting on the wall. And they are so thin that they can be actually confused with the capillaries of the vasa recta, which are present in very close proximity. You will find that the RBCs are present within the vasa recta capillaries and they are not present within the loop of Henel. And that's how you will differentiate the two under H&E. If you see the longitudinal section of this medullary region, you can see that you have got these collecting ducts, you have got these larger collecting ducts, and you have also got this narrow Henel's loop, and the cells of the Henel's loop have got much less cytoplasm, and they appear to be protruding into the lumen in the form of hobnail structures. Apart from that, you also have a layer of interstitial cells which are present between the segments of the Henel's loop and the adjacent vasa recta, somewhat like the rungs of a ladder. In this illustration, in this virtual slide, you can see the various elements which are present towards the inner medulla. So you have got mostly the collecting ducts, but at the same time, you have also got the vascular elements of the vasa rectae, and you have also got the smaller structures of the Henel's loop. So here you have got the collecting ducts. Various collecting ducts are seen here in close proximity, and you have also got the Henel's loop over here with the cells appear to be hobnailed and protruding into the lumen. You also have the capillary vessels of the vasa rectae. With ISC, you can differentiate the various layers. You can differentiate the various tubular elements which are present in the medulla. So you have got the central vascular bundles, which are again surrounded by the descending straight tubules. These descending straight tubules will not express pancytokeratin. This particular slide shows IHC expression of pancytokeratin in the various epithelial elements which are present in the kidney. So these descending straight tubules will not have expression of cytokeratin. On the other hand, these larger tubular elements which express cytokeratin are basically the collecting ducts, and these smaller tubular elements which are expressing cytokeratin are the ascending thick limb of Henle. This is again a dual immunostain in which immunostaining has been performed both for CD31 as well as for smooth muscle actin. So CD31 highlights the various vascular elements which are present within the vasa recta in the medulla, and you can see that you have got structures in the form of arterioles, veins, as well as the various capillaries. The arterioles are the ones which have the smooth muscle in the wall, while the venules and the capillaries will not have the smooth muscle actin expression. So this is the structure of the inner medulla. As you can see, the image A shows you the various important constituents of the renal medulla. You have got the you have got the collecting ducts, and you have got the thin limb of the loop of Henle, which are very difficult sometimes to differentiate from the capillaries of the vasa rectae. When you do cytokeratin 7, you see that there is positivity both within the collecting ducts as well as in the Henle's loop. And if you were to do a CD31 immunostain, you would see that the stain would pick up the positive vessels which are present within the vasa rectae and in between the tubular elements of the collecting duct and the loop of Henle. Coming to the last component of the renal system, that is the collecting system. As we already know, the renal medulla opens out into the renal collecting system at the renal papillary tips, and it opens out into minor calyces. There are 9 to 11 funnel-shaped minor calyces that basically surround these renal medullary papillary tips, and these minor calyces join in groups of 2 to 3 to give rise to major calyces. And these major calyces again unite to give the renal pelvis, which ultimately joins into the expanded upper portion of the ureter. There is no distinct delineation between the renal pelvis and the renal ureter, and rather it is a kind of a gradual kind of transition. However, one important structure by which you can differentiate the minor calyces from the renal pelviureteric system is the presence of the smooth muscle elements. Smooth muscle elements will not be seen in the minor calyces, but as you go lower down, you see that there is an expression of smooth muscle within the wall as well. So this is the structure of the renal pelvis, wherein you see that the renal medullary pyramids at the papillae are draining into the minor calyces. 2 or 3 of these minor calyces are joining to give rise to the major calyces, and these major calyces are around 2 to 3 per kidney, and these will ultimately join into the renal pelvis and ultimately descend into the ureter. So this slide basically shows you the orientation of the renal medullary pyramid papilla, which pushes into the underlying minor calyces. As you can see, there is a urothelial layer which is sitting atop the minor calyx, while the renal medullary pyramid, that is the papilla, shows you mostly the collecting ducts and as well as the blood vessels of the vasa recti. So this is how it would look. The renal calyx would be lined by urothelium, and just under the renal calyx, you would have the renal papilla of the renal medulla, which is mostly composed of the collecting ducts. As you can see, there is no smooth muscle within the minor calyces. On the other hand, when you look at the renal pelvis, which is lower down, you will see that atop is the layer of urothelium, but then below you have got the nice thick muscularis layer which is present and which helps to segregate the structures of the renal pelvis from that of the minor calyces. So you have got the renal papilla over here, which is covered by again urothelium to a certain extent, and lower down you have got the collecting duct elements, and these collecting ducts can also be sometimes covered by a urothelial layer over the minor calyx. In this virtual slide, you see the nice illustration wherein you can see that there is this renal medullary papillary tip which is protruding into the minor calyx, and within the renal medullary papillary tip you have got these collecting duct elements along with the elements of the vasa recti. A higher power view of the same, as you see towards the left, you have got the renal medullary papilla composed of mostly the collecting ducts, And towards the right, you have got the multilayered urothelium, which lines the minor calyx. So you've got this urothelial layer, which is sitting atop the minor calyx. And at the renal pelvis, the urothelial layer is the maximum thick, and you can appreciate all the layers of the urothelium, which is ultimately ending into the superficial umbrella cell layer, which have got very densely eosinophilic cytoplasm. And lower down, you have got the intermediate cells and the basal cells. So that's all about the renal histology. It's actually not too complicated. All you need to know is how to segregate the renal cortex from the renal medulla, know how the orientation of the minor calyces to the renal medullary pyramids is, and you also have to have a little bit of understanding about the renal medullary pyramids, that is the medullary rays, as they dissect into the overlying cortex. Thank you very much.